Okay, one of the skills we worked on for the last couple of units was assessing a respiratory patient. And we know through OPQRST, sample history, through checking our A, B's, and C's, we can get a great idea of what's going on with this patient. So our patient is having difficulty breathing today. We listened to many lung sounds. We can hook him up to pulse ox. We'll hook him up to capnography. And again, won't stay on since we don't have ears on our person. And after doing that assessment, we hear wheezing. We find out he has a medical history of asthma. We find out that we forgot the inhaler at home today. And we are going to go ahead and treat this asthmatic patient. Okay, so we have many tools that allow us to differentiate a respiratory patient between asthmatic, COPD, CHF, pulmonary embolus, anxiety. Of course, medical history is a great tool, so the meter dose inhaler prescribed to the patient is a key one. We also have our pulse ox and our end tidal tracing. So the shark fin tracing is a classic sign of a asthmatic patient. A short inhalation and a long prolonged exhalation. Our patient is breathing a little fast, so we have a lower end tidal reading at this time and a lower pulse ox reading. This is just another example of what a shark fin might look like. Again, a very hallmark sign of a asthmatic patient having an asthma attack. And of course we have one of the most easily done things is using our stethoscope to listen to the wheezing, and we'll see if this picks up. Okay, we are very confident that this is an asthmatic patient, and we're going to treat this asthma attack of this patient. So we're going to explain our procedure to our patient, of course get consent from our patient. We're going to confirm our 5 rights for albuterol and Atrovent, confirming the right patient, medication, dose, route, time. We're going to check the expiration date. We're going to check for allergies and the appearance of both medications. Remember, you have 2 medications. So we need to do that for both. So we're going to rule out any contraindications for albuterol. We're going to assemble our kit. So we're going to take our cup. We're going to take our 2 medicines, which again look very similar. Put them both in. And put the lid on. We're going to find the T plate thing. We're going to find the mouthpiece. We're going to find our exhaust. And we have our oxygen tubing. We're going to hook it up to 6 liters, 6 to 8 liters per minute. And we would expect to see misting here and some bubbles here. I'm going to shut this off so you can hear. And then we're going to instruct our patient to put the mouthpiece into their mouth, inhale slowly and deeply, holding each breath for 1 to 2 seconds if possible. I am a huge fan of the neb mask, which allows the person to have their hands free and not have to worry about that. So we also have capnography going still. And then after we're done administering the medication, we reevaluate the patient's response, and then we do our right documentation. So we want to document the patient's name, the medication we gave, the dose, the route, the time, the tolerance to the procedure. So did we get better? Did we get worse? The name of our medical control physician or protocols, and the name of the EMT that administered the drug. And then we'll reevaluate the patient's response to the medication and consider repeating if our protocols and conditions allow. Okay, we will reevaluate our asthmatic patient a few ways. One, of course, is our numbers and our screens. So our capnography is returned to more of a plateau. Our respiratory rate, pulse ox, end tidal is all kind of returned to normal values. And just to show you what another normal end tidal tracing looks like, nice plateau looking normal, inspiratory and expiratory. Of course, our most thing to use would be our stethoscope and patient assessment, and of course we would expect to have normal breath sounds. And we would reassess our dyspneic scale, our level of difficulty breathing, and treat accordingly. Okay, we have a respiratory patient who is really sick and requires CPAP. And some of the indications for CPAP, we have increased respiratory rate, usually over 25, obvious nasal flaring, intercostal retractions, possibly wheezing if it's an asthmatic. We have rales that suggests CHF. We also have our COPD patient, pulmonary edema, which would again be rales, and we have an O2 saturation under 93% on high flow oxygen. So some rales. And of course, we have some contraindications to CPAP. So your patient who does not get CPAP would be someone in respiratory arrest, agonal respirations, or unconscious, because they have to be able to maintain and breathe on their own. Anyone that's a shocky state, so low blood pressure, a trauma patient, someone that's recently had a tracheostomy, someone who is unable to cooperate, unable to follow commands and listen, and of course someone who is quite nauseous or vomiting will not get CPAP. Okay, so setting up the CPAP, just remember there's 20 different brands out there. The ones we have here in the building usually require you to hook up your green cable to the threaded adapter here. You can still use your oxygen port. However, to power the oxygen port means you have to have the bottle on. To have the bottle, as soon as you turn the bottle on, you are powering your CPAP. So that connects to the back of your CPAP device and of course your tubing. Your mask, it's like a bag valve mask. And this specific brand has different CPAP valves. So this one is a 5, and we have a 7.5, and we also have a 10. And most of the time you start out with a 5, you evaluate your patient, see if they tolerate it, and if things are not going for the good, so to speak, you bump it up to 10. And that adds a little bit more back pressure. And of course you have your strap, and make sure that you explain this to your patient and that they're comfortable with this. We'll take off the non-rebreather mask. We will leave on the CPAP, we will leave on the end tidal so we can continue monitoring that while patient's on CPAP. Okay, putting these masks on are not always the easiest thing. I recommend putting one side of the straps on first. If you are going to put the mask on the patient and not turn the CPAP on right away, you need to take out the exhalation valve so they have a port to breathe. Otherwise, what usually happens is you put your kit together, you turn the machine on, and then place the mask on the patient, creating a nice tight seal. And remember, they will be taking in the air at this time. And you definitely need to coach them through this, tell them what's going on, calm them down. A lot of times they'll be anxious. And then we'll turn it on. It is quite loud most of the time, and of course it's not that loud right now because our patient isn't breathing, but it is nearly impossible to verbally communicate with your patient when this is on. The last part of CPAP is reassessing your patient to see if your patient has gone south or north. One of the best ways is to talk to your patient, visually look at that patient. If they're getting better, they will just look better. They won't be so anxious, won't be so nervous. Of course, we have our numbers. Pulse ox should normalize, end tidal should normalize, respiratory rate should come down. Breath sounds, of course. You would expect to hear some normal breath sounds as all that fluid is pushed back out of the lungs. And if the patient does not improve, if they're still really struggling, if things are still really bad, on this device, you can take out that 5 centimeters of water resistance and put in a 10, and that will increase the amount of end expiratory pressure that patient receives every time they're exhaling, and that should help. And if it doesn't help, then it might be time for paramedic intercept to possibly intubate this patient and take away their ability to breathe, and then in turn breathe for them.